So today's session is our third session in this webinar series, and it's okay if you haven't been able to attend the first two, but today is about translating data into practice for optimal management of nccRCC. And our faculty today is Dr. Powell from City of Hope Comprehensive Cancer Center in California. And so Dr. Powell will give a presentation, then we'll go into a case study. If you have a case or a question about a case that you're working on and you'd like to pose that we welcome and encourage that towards the end of the session, as well as time for Q&A. I will be launching some Zoom polls throughout the session today, and do encourage your participation as it just helps us gather some data on this session. And that's about it. At the end of the session, I will put a link to a rapid recap in the chat, which kind of summarizes everything Dr. Powell will go over. And I will also put the link to the evaluation in the chat. So Dr. Powell, I will go ahead now and turn it over to you.
Great. Thanks a lot. Well, it's great to see everyone on. I know this is always a tricky time to get folks to join a session like this, but I appreciate you all jumping on the line. Should I go ahead and share my slides, or would that be better?
Yes, that would be great.
Great. Excellent. I see some names that I think I recognize. I don't know if it's the Brian Lane that I know and love from the GU world, but it's great to have you on. And, certainly because this is a small group, we can make it really interactive, and do feel free to sort of jump in if you have any questions or comments along the way. So I'm going to, let me see here. I was mentioning to Ashley, I'm on a different computer today than usual. So I'm going to go ahead and tinker with this a little bit. 1 second here. Okay. The only thing I'll probably struggle a little bit with is going backwards, but I should be able to share my screen for the most part here. We're going to be talking about non-clear cell RCC. We've had previous sessions that are really sort of dedicated towards the topic of, really toxicity management, identifying the various histologies and so forth. And today we're going to get into the nitty-gritty of some of the really exquisitely rare subtypes of disease. And that's not something we get a chance to talk about too often. So I'll be your faculty today, but I really want to thank Dr. Pedro Barata, who's been really instrumental in putting these programs together. And of course, the team at the France Foundation, who have just been terrific. The France Foundation puts together a lot of terrific CME activities, and you can see the various accreditations listed here. And if you'd like, you can scan the QR code there for the syllabus for the course. This may not take the entirety of the hour. I'm more than happy to answer any questions that folks have going along here. But after the session, we'd like for you to be able to describe the rationale for various combination therapies and really understand and develop the knowledge and skills to select patients for appropriate therapies based on individual tumor biology. And I'll explain what that means shortly. We're going to talk about the rationale for various combination therapies and then get into the nitty gritty. And this is the bulk of the talk on SMARCB1 deficient renal cell, chromophobe type renal cell, collecting duct, FH deficient, so on and so forth. There's lots of various subtypes. Then we'll go through some presentation and discussion of patient cases. So first, we'd like to begin with asking what you have to know already about this. So which treatment regimen has shown limited, if any, anti-tumor activity in patients with chromophobe RCC? Is it just a checkpoint inhibitor alone? Is it lenvatinib, everolimus, cabo, and nivo? Is it a combination of 3 agents in unison, cabo, nivo, and nivo? I'll give you guys a second to respond to that. I think we'll see the poll pop up in just a second. So I think this is a very astute audience. Looks like most folks are suggesting that a checkpoint inhibitor alone may not be enough. And I think that's right. And on a scale of 1 to 5, how would you rate your level of agreement with the following statement? I am familiar with the sequencing strategies for the treatment of clear cell renal cell carcinoma, non-clear cell, I should say. How familiar are you with this? Let's see here. I'll give folks a moment to respond. So looks like we have, some folks who strongly disagree, some who agree. This is a tough one because I think even if you have a lot of expertise in the field, there's many clinical scenarios where there really isn't a defined sort of standard of care here. So let's go through some of the rationale for combination therapies. So many of the monotherapies that we have for non-clear cell RCC have activity in the range of 3 to 27%, doublet therapies in the ballpark of 20 to 48%, triplet therapies, as we'll see in a moment, 21%. I would say that there's a real call still for us to understand how these different elements work through randomization, if at all possible. I definitely think that there's certainly a role for that moving forward. When you look at the most aggressive potential strategy here, that's triplet therapy with the combination of cabozantinib and nivolumab and ipilimumab. One of the things that really sort of stands out is that you can actually see here that it's not necessarily better to throw the kitchen sink in a patient as compared to maybe going with a doublet approach or a singlet approach. This isn't comparative data, but what Brad McGregor showed in this trial that was presented at ASCO a couple of years ago now is that if you use cabozantinib, nivolumab, and ipilimumab, you end up with a response rate of 21%. So good, not great. Median progression-free survival is 9.7 months. If you sift through the data in a little bit more detail here, one of the things that stood out to me is that chromophobe subtypes seem to have some benefit here. You can see at least some tumor shrinkage, one patient who actually had a response. And if you look at papillary subtypes, again, there perhaps, there might be some benefit that one can ferret out, but not a clear signal. And of course, I think data sets like this really warrant a little further follow-up. The median survival in this study wasn't reached yet. This is a great study run by Deepak Kalari that was presented at ESMO last year. And if you look at the data from this one, you can see that the combined checkpoint inhibitor approach, like with nivo-ipi, the VEGF ICI approach, or just the VEGF or mTOR combination approach, was assessed across a broad swath of individuals. And you can see here that perhaps in this retrospective experience, and it's always difficult to characterize these patient cohorts retrospectively, it looked as though there was some activity of combination therapy across papillary subtypes primarily, some activity in chromophobes, some activity in the context of unclassified. It's interesting, when you looked at nivo-ipi in this retrospective experience, you actually see a response rate better than I would expect. They're quoting a response rate of 50% in chromophobe subtype disease. There's lots of caveats to that. Sometimes chromophobe can be admixed with sarcomatoid features. You never know if that's really sort of the driver of response, if you will. So lots of considerations here. But I do think that this retrospective data is somewhat helpful. Treatment sequencing strategies. Let's say you have a 62-year-old patient with metastatic papillary RCC that progressed after first-line therapy with cabo. Appropriate therapy based on current evidence. Again, this is papillary disease. So it'd be axipembrin, nivo-ipi, lenab, or sunitinib. It's actually a really tough one. Putting in the chat here when I do it, or not in the chat, in the survey, when I do it in clinical practice, but I don't know that there's necessarily an obvious choice here. Let's see what folks respond with here in just a moment. So it looks like almost everybody favors lenvatinib and everolimus. And that is, in fact, what I chose under the circumstances. If you look at the NCCN guidelines, if a patient has had cabozantinib and nivolumab in the frontline setting, that constitutes one of the preferred regimens. Cabozantinib alone could also be considered a preferred regimen. Lenvatinib and pembrolizumab is a potentially preferred regimen. And you can see other recommended regimens to the second or third line setting listed thereafter. And that includes everolimus, nivolumab, pembrolizumab, sunitinib. So, all of these strategies could potentially be applied in the second line setting, although, there is no obvious de facto standard. You can see that when you look at the algorithm, and this is really, really important to keep in mind, for patients with non-clear cell metastatic RCC, clinical trials remain the preferred option in the first line setting and in the second line setting. So I always like to, suggest to individuals that if we can get them on a clinical trial, that certainly benefits the field, and it's, in my opinion, the right approach moving forward. Now, what do guidelines say outside of the U.S.? Well, these are the EAU guidelines. I often like to refer to these. It really underscores the need, I think, for future research. Despite the fact that I think that we've got fairly large randomized data for cabozantinib and papillary RCC, you can see that the strength rating that is offered is weak. You can see that lenvatinib and pembrolizumab or cabo-nivo to the other regimens. And I think people would typically consider up front, those are also given weak recommendations. So at this point in time, although this is a talk on that includes some guidelines are admittedly quite weak. I think we definitely need to consider clinical trials. Cabozantinib monotherapy constitutes a preferred regimen for metastatic papillary RCC in the ESMO guidelines. You can see that lenvatinib, pembrolizumab, and cabo-nivo are considered alternatives that have weaker ratings, so to speak. And you can see that cabo or sunitinib or everolimus or pembrolizumab are all potential second-line therapies. And these are guidelines that are followed, I would say, in a good part of the world. So it's interesting to see the treatment algorithms that are rendered elsewhere. As I look to the guidelines as they're spelled out against the other non-clear cell subtypes, you can see that for chromophobe disease, sunitinib, pazopanib, lenab, everolimus, lenpembro, these all carry fairly balanced recommendations. We can certainly go through the nitty-gritty of how to evaluate those. For collecting ductal medullary, this is a really, really tough one. We're going to go through some of the limited data that we have in this context, but they mentioned that platinum-based chemotherapy is an option, and I think that's not unreasonable. And then for sarcoma to the predominant disease, it's really the suggestion that nivolumab and ipilimumab is preferred, and I think one has to agree with that based on current evidence. So let's go into some of these relatively rare subtypes of disease. When I think about renal medullary cancer, this new term SMARCB1 deficient has been introduced as well. This is a disease where, again, I run into 5 or 6 cases in my career, and that's in the context of me seeing thousands of patients with RCC. So this is an exquisitely rare diagnosis. I usually lean on my colleagues who have real expertise in a specific subtype to understand the treatment algorithm. So this is a slide that I put together with the assistance of my colleague Pavlos Vasul, based on his advice. So he suggests typically starting with platinum-based chemotherapy. He suggested going next with gemcitabine and doxorubicin, then perhaps EGFR targeting regimens. I think the one thing that really sort of resonates is that he had suggested that immunotherapy may actually lead to a patient's detriment. And I know that's really hard to conceive of. I mean, we usually do like to throw immunotherapy at renal cell carcinoma, even non-clear cell histologies. It's a bit of a Hail Mary pass, sometimes. But, I think here we have to be really careful of the potential for what it can do adversely to tumor. One thing that Pavlos has cautioned me is that, if you have a patient who's potentially a candidate for chemoradiation, which is systemic therapy alongside radiotherapy, that's certainly something that can be considered. This is a different showing of, how to manage this, again, through Pavlos's expert guidance here. So again, he suggested platinum-based chemotherapy, gemcitabine, doxorubicin, and then EGFR-directed therapies. He suggested that you wait on radical nephrectomy. That's oftentimes a question that comes up. These are young patients with aggressive disease. Is there a priority taking them to the OR and taking out a worrisome primary lesion, or is it to get them right onto systemic therapy? And Pavlos has really sort of reaffirmed that systemic therapy should be the priority here. This is interesting. So, what Pedro did, which I think is quite important, is to get his finger on the pulse of what people would prefer ahead of his ESMO talk. He gave a brilliant ESMO talk last year on clear cell disease, on papillary. Would it be sunitinib, cabo-nivo, or lenvatinib, pembrolizumab? But he suggested cabo-nivo, but it's important to bear in mind that a lot of patients aren't getting these types of treatments. I, here in the US, actually prescribed for a patient the combination of cabozantinib and nivolumab, and was told that sunitinib was really the preferred medication for papillary disease. And this was actually 2 years after we published the data from the PAPMET clinical trial. So I was quite surprised to hear this. So the key takeaways for sequencing are that treatment recommendations really vary across international guidelines. The treatment sequencing recommendations are very specific in the context of SMARCB1 disease. If you have advanced papillary RCC, the treatment in any given clinical practice may potentially differ from guideline-based recommendations. So we talked a little bit about SMARCB1 deficient renal cell carcinoma. One of the things that I'll point out here is that, if you do have this disease, there's regimens such as bevacizumab or erlotinib that could be considered. We talked about EGFR-based targeted therapies, and that's on the basis of some literature suggesting potential PFS benefit and potential response rates on the order of around 20%. Gemcitabine and doxorubicin chemotherapy has also produced response rates on the order of around 20%. So these are all elements that one's going to potentially keep in mind. When you look at the data for bevacizumab and erlotinib, and this was done by Pavlos's group, they had a total of 10 patients. And you can see some patients with tumor reduction. There's not really an extended progression-free survival with this regimen, but you can see at least 1 or 2 patients at the tail of the curve there. Doxorubicin and gemcitabine does actually seem to produce at least some objective responses. Again, this is based on Pavlos's data, which he published in Clinical Genitourinary Cancers. And you can see some patients with a downward sort of trend line in their tumor growth, progression-free survival. Again, very modest, overall survival modest. But again, these are salvage regimens that we might consider. Now, what about chromophobe renal cell carcinoma? Chromophobe renal cell carcinoma can really be managed by a whole broad swath of strategies. But if you look at this really nice table here that Pedro's constructed, one of the things that really sort of resonates with me is that it's really the lenvatinib-based regimens that sort of stand out in terms of their response rates. So you can see here response rates in the order of 40 to 44% with lenvatinib-based therapies. And I would say that that really does represent at this point in time kind of the high watermark when it comes to treatment with a chromophobe type disease. There is some data for the combination of bevacizumab with their everolimus, although I have to say that this is a very small cohort of 5 patients. I just don't know whether or not to hang my hat on it. This is a wonderful multi-institutional experience that was done by Dr. Doshi from Sloan Kettering and presented at ASCO last year. And these types of experiences are important. You can see here, it's not a huge number of patients, but having said that, we don't have that luxury, I would say, in this disease. And it certainly stands out to me that perhaps the TKI combos do a little bit better in this particular context. But again, no obvious answer, I would say. What about collecting duct disease? So collecting duct disease is a disease that we talk to fellows about and really have the fact that this behaves a lot like urothelial cancer. So as opposed to the approach where we might consider in the context of kidney cancer targeted therapies and checkpoint inhibitors, we oftentimes do suggest that patients with collecting duct carcinoma start with platinum-based chemotherapy. I've done cisplatin gemcitabine or carbogemcitabine for years in this cohort. Checkpoint inhibitors, at least based on the data from Nivo/Ipi, don't seem to really garner a lot of responses. There's one trial that we'll highlight in just a second looking at cabozantinib that does show some promise. So this is the data from Stefan and Dart, published years ago in the Journal of Urology, that suggests a progression-free survival of 7 months and overall survival of 10 months in 23 patients getting either cis or carbo alongside gemcitabine for collecting duct kidney cancer. This is, I would say a modest response rate indeed, a modest PFS and OS indeed. But having said that, I have seen some patients with very protracted responses to cisgem in this setting. The Bonsai trial, I love this name, was done by Italian investigators led by Giuseppe Procopio. They published this in JAMA Oncology, and I think this was appropriately a high-profile publication because, again, it encompassed this exquisitely rare population of patients with collecting duct disease. So these patients all received cabozantinib monotherapy, and you can see a progression-free survival of 4 months, OS of 7 months here. And again, it represents a potential standard in this setting. FH deficient RCC. I saw a patient who was just diagnosed with this not long ago. FH deficient RCC is a rare entity. Again, this is one of those that we may not see often in clinical practice. It's one where there's interesting data. This was a cohort assembled by Ram Srinivasan, suggesting that beverlotinib resulted in a response rate of 72% across 43 patients. This has still not yet been published after many, many years. I'm a little skeptical that it hasn't been published yet. I'd love to see it out there in the literature. And there was a trial presented actually at ESMO last year, in fact, which suggested that with a combination of sintilimab and axitinib, so sintilimab is a checkpoint inhibitor, axitinib, but targeted therapy, you see a response rate of 63%. That was a small study with 19 patients, but nonetheless impressive. Look at this data for sintilimab and axitinib. You can see most patients here actually having a very substantial reduction in tumor burden with this combination. You can see the median progression-free survival still not reached within this cohort. So I would argue some very, very impressive data here. Bevacizumab and erlotinib, again, I'd love to see this data published. Median PFS of 21 months, really impressive for this combination. I can say that I've tried this in clinical practice. I haven't always had the same response, frankly, but it is quite compelling, and you can see a substantial change in tumor size over the course of time. This has led to a phase 2 clinical trial, in which patients are receiving a combination of bevacizumab, atezolizumab, and erlotinib. Really interesting combination study. It's a small trial of 42 patients. It's going to be curious to see how these patients do over time. Next is translocation-associated RCC. There have been multiple very, very small attempts to look at this particular disease. And you can see the numbers here really sort of ferreted out. And again, a wonderful table from Pedro. And you can see response rates all across the board, but hard to really sort of trust these response rates with such low denominators. But as you look across the spectrum over here, it does seem as though there might be a potential signal of increased responsiveness as you look to IO-based combinations. So cabo-nivo stands out to me, pembro stands out to me here. The combination of bevacizumab with atezolizumab stands out to me here. But again, this is based on relatively small numbers. This is some data that was published by Omar Al-Halabi from MD Anderson in The Oncologist. And this is impressive data that looked across 18 patients receiving checkpoint inhibitors, nivo-ipi, 11 patients getting VEGF inhibitors. And it looked as though perhaps there might be an edge in responsiveness when you look at patients getting the combination of VEGF inhibitor, checkpoint inhibitor there. Progression-free survival seemed to be pretty similar between these two groups. So, and this is some data segregated by patients receiving bevacizumab and atezolizumab in a pivotal phase 3 clinical trial. And you can see the data in translocation RCC, again, really favoring the use of a VEGF-directed therapy in this context. It's not a slam dunk by any means, but something to consider. So what are the key takeaways here? For chromophobia RCC monotherapy or combination therapy with mTOR everolimus may elicit response rate up to 44%. I would suggest that lenvatinib may be a key component of therapy for patients with chromophobe type disease. For collecting duct renal cell and SMARCB1 deficient, TKIs and chemotherapy has shown efficacy. And for patients with VH deficient RCC, response rates of up to 72% have been observed at the VEGF backbone with either beverlotinib or sintilimab, axitinib, as you saw. For translocation RCC, the best outcomes are with the TKI checkpoint inhibitor combinations, and checkpoint inhibitors in combination don't appear to be effective. So what did you learn today? Which treatment regimen has shown limited, if any, anti-tumor activity in patients with chromophobe RCC? Let's take one more stab at this. I think most folks actually got this question right at the outset, so I don't think we need to dwell on this too long. Let's see what folks respond with in just a moment here. Okay. Sorry, well, there we go. So checkpoint inhibitor monotherapy. Yeah, I would suggest that really doesn't have much anti-tumor activity. Lenvatinib everolimus, I think, does. So by all means, I'm open to taking any questions that you might have around treatment sequencing for non-clear cell combination strategies or tailoring therapies to individual patients. I've got my chat up here. So if there's anything that you would want to ask, please do feel free to use the chat or feel free to unmic and ask any questions. But I really do appreciate your discussion today. Any questions before we move on to some cases? I'm going to jump into some of the cases then. So let's take a healthy male in his 60s who presented to his primary care physician with flank pain and hematuria. You find a 6-centimeter mass in the right kidney. The patient has partial nephrectomy showing grade 3 papillary RCC with sarcomatous features. The tumor has met amplification, and this patient undergoes surveillance. You do a biopsy after 12 months to show papillary RCC. So we talked a little bit about treatment options that are available and preferred for this patient. We suggested that if the patient just has a single isolated site of disease, by all means, I think that we can consider metastasectomy. But if it's more widely metastatic, a clinical trial is preferred. Systemic therapy is certainly an option. We went through some of the various options for patients with non-clear cell RCC. You can see that patients may favor regimens such as cabo-nivo or lead-pembro if they're looking for a combination regimen strategy. Cabozantinib by itself is also an option to consider here. And based on clinical trial data, we might consider cabo-nivo. I would say that everolimus, radiation to the lung, and nivolumab are a diverse area of options. A tumor board reviewed this patient's case and determined they weren't eligible for therapy, but based on multiple factors, the patient ended up getting cabo-nivo. So in this particular patient's case, we see that there's a paucity of data, I would say, regarding, how to optimally manage these patients with phase 3 clinical trial data. But nonetheless, I do think that the paucity of evidence suggests that if a clinical trial is available, that should definitely be the preferred approach for patients. I think that tailoring treatment decisions and a multidisciplinary tumor board are really key. Any questions about this case or other patients you'd like to discuss at this time? So again, key takeaways we've already highlighted. A summary of the syllabus is seen below. Which of these key takeaways would you say is perhaps the most important, would you say? You'll see a little survey pop up here in just a moment. We'll give folks a moment to respond to that poll, but then Ashley will broadcast the result. Let's see what folks choose here. So the collecting duct and chromophore data seems to be quite relevant. And then we have another poll for you, which asks, which of the following strategies might you consider after today's program? Would you consult treatment guidelines, follow ongoing clinical trials, use more TKIs or ICIs, or increase focus on enrolling patients in clinical trials? And you can choose multiple options here as suggested. So, or if there's other takeaways, by all means, we'd be very curious to know what those are. We will give you guys a moment to respond here. Okay, so it looks like a lot of folks suggesting that they might focus on clinical trial enrollment and consult clinical treatment guidelines. Very good. So if you want to claim CME credit for this activity, please use the QR code up top. Your password's going to be RCC, and you can register for the fourth and final session, which really focuses on toxicities using the QR code at the bottom. Happy to answer any questions. I'll stop sharing my screen now, and I want to thank everybody for their attendance.
Hi, Monty. Joseph Conrad here, Merck Medical Affairs. Can you hear me?
Hey, Joseph, how are you?
Doing well, thank you. Nice to see you. Kind of a general question here. I often think of non-clear cell RCC as and the treatment landscape as a biomarker-driven one, given its histological classification. But I wonder, given the challenges of finding specific precision biomarkers that predict response, or the challenge in finding a really substantial patient population with those precision biomarkers, are there any molecular subtyping approaches that show promise with a bigger genetic fingerprint? Are there promising therapies that might find a niche there?
Yeah,
thanks.
Yeah, first of all, thanks so much for attending, and great question. I do recommend genomic profiling for all patients with non-clear cell RCC. I do think that sometimes it helps with sort of a needle in the haystack approach. It's not everybody in whom you'll find an actual biomarker like MET or what have you, which might point you in the direction of a MET-directed therapy, for instance. But there are rare patients. We published a series of these a couple of years ago in European Urology who had ALK translocation. And those patients might actually be candidates for treatments such as ALK inhibitors, which we use in non-small cell lung cancer. So that's a really interesting approach that we took with some really great responses. So I strongly encourage individuals to do genomic profiling if possible in this subset, although it may not always lead to an obvious treatment choice.
That's a great response. Thank you.
Thank you. Any other questions? thank you all for attending and appreciate your interest. I'll turn it back over to Ashley.
Again, thank you all. I put the rapid recap in the chat. I put the link to the evaluation in the chat. I will also send out an email to everyone after this with the same information. And we have one final session remaining, session 4. And there's 2 options to attend that in April 10th and April 16th. And I will also include that in the follow-up email. So if you have any questions or anything that I can help with, please feel free to reach out. But otherwise, I think we are done for the day. Thank you, Dr. Powell, for the presentation.
Thank you. Bye, guys.
Have a good day.